Yeah, election too. Yeah, thank you. So during the first election, we actually addressed the main functions of human kidney in a very brief manner. So our purpose here is not to explain the full medical background or a medical explanation of what kidney is, because basically engineers are not in position to dive into this topic too deep. But at the same time, engineers have to develop at least very basic understanding of what exactly happens in a human kidney in a terms of blood filtration, to understand what kind of device we have to develop to help people with uh, issues with kidneys, especially when it goes to chronic kidney disease. So yeah, just to emphasize again this point, if we talk about the development of medical equipment that is supposed to help people with different medical conditions, we need to introduce many specialists from many fields who will participate in achieving the same goal. And in this lecture, I would like to talk about the treatment of kidney failure and renal replacement therapy. So we just discussed the problems that will happen if during the development of chronic kidney disease. First of all, it's the accumulation of uremic toxins and its accumulation of water in human body. It's the um, disappearance or malfunction of any other kidney functions like endocrine function and reabsorption function, water reabsorption, nutrient reabsorption, etc. So basically, what happens to a human organism without kidneys is the disturbance or um, basically homeostasis becomes a very difficult matter for a patient. So in terms of people with chronic kidney failures, we have to think about the possibilities of how exactly we are going to help people with this condition. First and foremost, like the main issue that has to be resolved in that term is, of course, the blood filtration and removal of excessive water from the human organism. Because if we do not do that, that means that there will be a constant accumulation, a continuous accumulation of uremic toxins and water in a human organism, which leads, in terms, will lead to the um, increase of these parameters in human blood, accumulation of excessive fluids in different parts of the human body that will develop uremia as a main symptom of the blood intoxication, and that will become the main one of the main causes of death for people with chronic kidney failure. Yeah, let's we already discussed that. So, in regards of the chronic kidney disease, as we discussed earlier, the most logical solution we can provide here, of course, is the organ transplantation. That actually relates to the issue that we, speaking of these apparatuses and other renal replacement therapy, the only function that we can replace with those particular methods is the blood filtration. That means that we remove the excessive toxins and excessive water from the human organism. But at the same time, yeah, at the same time, we have the lack of endocrine function. We have the lack of the hemostasis function, etc., and so on. So yes, the most logical solution is the organ transplantation, because we basically remove the dead kidney with the healthy kidney, and thus we manage to restore the all missing functions of the human kidney. Yeah, let me. Uh, yeah, basically, let me just foreshadow this particular. Yeah, if we address this particular market of renal replacement of the end-stage renal disease, and we talk about the organ transplantation as the golden standard of renal replacement therapy, we will quickly figure out that there is a lack of organ transplant organs to supply all patients who suffer from chronic kidney disease. That means that the huge chunk of people who suffer from different stages of chronic kidney disease, including patients who suffer from terminal kidney failure, they will require other means of blood filtration. And another issue with organ transplantation is, of course, that in some cases the donor organ will basically be affected by the response of immune system, which will basically will lead to the problem that a person who just had the human transplant organ will still require other means of renal replacement therapy if the immune system just suppressed the work of this organ. So speaking about the alternatives to the kidney transplantation, first and foremost, we talk about the dialysis as the main method of renal replacement therapy. Basically, we have the two major methods of the renal replacement therapy that can be related to dialysis. It's a hemodialysis method, which is basically extracorporeal method of blood purification, and peritoneal dialysis, which is intracorporeal method of dialysis regeneration. So, like a small comment, in terms of the hemodialysis, we usually have the external mass exchange unit that basically works as the a device for blood filtration. So if we decompose this particular hemodialysis apparatus, we have the external dialyzer that basically works as the filter for human blood. And in order to properly filter blood from toxins and excessive water, we need to use the artificial buffer solution called dialysate that will accept through diffusion the toxins from the human blood, and it will accept the excessive water by means of the hydrostatic pressure that we develop in the perfusive counter, the perfusive unit of the hemodialysis system, and the spent dialysis solution goes to the waste. So this basically the method where we constantly replace the dialysis solution within the dialyzer to maintain the high clearance of the uremic toxins and high water filtration rate. The alternative for the hemodialysis will be the peritoneal dialysis method. That is basically, in this particular case, we use the peritoneal cavity as the mass exchange unit. So basically, it will work as some sort of a natural dialyzer, and we pour the solution for peritoneal dialysis inside of peritoneal cavity, and due to the connection between the dialysis solution and internal organs and internal walls of the peritoneal cavity, we observe the diffusion of metabolites from human blood to peritoneal dialysis, and we also manage to perform the ultrafiltration flow during the peritoneal dialysis. And after a few hours of the presence of this solution within the human cavity, we just pour the spent solution from the human patient, and we repeat this procedure again. So basically, the main differences in terms of ultrafiltration, do we have the, let me just, a small foreshadowing for the third lecture. So in case of both methods of dialysis, we need to perform the extraction or removal of uremic toxins and removal of excessive water, because with condition of chronic kidney failure, the patient himself will not be able to remove these toxins on the natural way. And speaking of the ultrafiltration flow, if we talk about hemodialysis, basically we still have the hydraulic coefficient, the water permeability. Then we have the hydrostatic pressure created by pumps that pour the blood inside of dialyzer. Then we have the hydrostatic pressure of the dialysis solution that goes from the opposite direction. And we have the same parameter of the oncotic pressure created by protein in human blood. And usually the membrane of the dialyzer is developed in the matter that the proteins and other big sized molecules will not go through the membrane. Otherwise, we will have the condition and albumin will just filter out from blood, and it will create a very dangerous precedent for the patient, because in that case, we will remove a essential blood component that will severely hurt the patient. In terms of the peritoneal dialysis, so it's the hemodialysis and peritoneal dialysis, we can take into consideration the same parameters as the hydrostatic pressure of blood, hydrostatic pressure of the dialysis solution, and we have the presence of the specific osmotic agent that actually provokes the ultrafiltration flow through the membrane of the peritoneal cavity. So we have to take into consideration the contribution of all solutes that are dissolved both in human blood and dialysis solution. So we'll basically have to take into consideration the difference of concentrations of these solids between the peritoneal membrane. And in that regard, we also have to take into consideration the contribution of the oncotic pressure of the blood and the oncotic pressure of the dialysis solution, because in case of peritoneal dialysis, some amount of protein will just be transported by means of whether diffusion or convective transport through the peritoneal membrane, and there will be a small presence of protein within the solution for peritoneal membrane. And we also have to take into consideration the lymphic flow, that basically the work of the lymphic system that tries to remove all fluid that we pour inside of the peritoneal cavity from the human organism. This parameter usually never equals 0. So basically, when we pour the solution inside of peritoneal cavity, we have to take into consideration that the system will try to remove this fluid from the peritoneal cavity. So in case of peritoneal dialysis, we will not be able to affect any of those parameters. That means that we will not be able to affect the pressure of the human blood, and we have to rely only on the osmotic pressure that is created by the difference of concentration of some specific substrates. In case of peritoneal dialysis, we have to make sure that the ion composition of the peritoneal solution will be pretty much the same as the ion composition of human blood. Otherwise, if we affect, for instance, the sodium level, for instance, we make a high concentration of sodium ion, this ion will go to the human blood, and we will thus increase the concentration of the sodium level in human blood, which is a very dangerous condition that should be avoided. So in case of peritoneal dialysis, we have to find some alternative for this specific osmotic agent, and usually the most common osmotic agent that is used in peritoneal dialysis is glucose. Due to its relative small size, it's like the molecular weight of this particular metabolite will be 180 grams per mole. So it's a relatively small-sized osmotic agent that can easily increase the osmotic pressure of the peritoneal solution, which can be presented by this formula. So it's osmotic pressure created by some specific substrate, which is equals the gas constant multiplied by the absolute temperature multiplied on the concentration of this specific substrate. And we need to make sure that the concentration of glucose in case of peritoneal dialysis will be higher, significantly higher than concentration of glucose in human blood, to make sure that we will make a specific difference in this particular parameter. Otherwise, when the diffusion of the glucose starts, the concentration of glucose in human blood and peritoneal dialysis will become equal at some point. That means that this parameter will be equal 0 at some point. And we have still the lymphic flow. That means that if we do not have any contribution of glucose in this system anymore, the lymphic system will start actively removing fluid from the peritoneal cavity, which will create the opposite effect that we try to achieve. So basically, in terms of ultrafiltration, that's the main difference between those two methods. So in case of peritoneal dialysis, we try to increase the difference between hydrostatic pressure of blood and dialysis. In peritoneal dialysis, we have no such opportunity to do that. So those parameters we cannot change directly. So we have to affect the osmotic pressure. Yeah, those are basically the main principles of the dialysis. So in terms of the small sized molecules and solutes like urea, uric acid, creatinine, bilirubin, etc., we can expect that these small sized molecules will easily diffuse through the membrane we use in our dialysis system. So basically, the main idea behind any method, of any dialysis approach we try to implement in the case of chronic kidney disease is diffusion and osmosis. So diffusion is basically a pace of, in case of dialysis, is a pace of transport of the small-sized molecules through the semi-permeable membrane that can be described by the Fick's laws. I think that you already encountered that equation at some point. So in case of one-dimensional system, we can describe it as the gradient of concentration, a difference of concentration at some dimension, like if we assume that there is some dimension x, then we consider the gradient of the concentration in that particular dimension. But if we experience diffusion in multiple directions, it usually writes down like this: diffusion coefficient multiple minus, of course, on gradient of the solute concentration. So usually it's a passive process that takes place when there is a difference of concentration of a specific solute between different parts of semi-permeable membrane or different parts of the solution. And the diffusion goes against the vector of concentration gradient. And this process happens until the dynamic stability occurs. So that means that the concentration of the solute between the different parts of this membrane will become the same, and the amount of solutes that goes from one side to another will be equal to the amount of solute that goes the other way. And the osmosis is basically a transport of the solution. So this is the transport of solute that is described by the Fick's law. And in case of osmosis, if we imagine that there is a semi-permeable membrane that is permeable for water but is impermeable for the solutes, and we have the drastic difference between concentrations of the solutes between the different parts of membranes, we can expect that water will go from across the concentration gradient. That means that it will go from the part with a smaller concentration of the solute to the part where the concentration of the solute is high. And again, the stability will occur when the concentration of the solutes will be the same. So it's basically the water transport in that regard, which takes place in peritoneal dialysis, with the only exception that when we use glucose, usually glucose can penetrate through the membrane. So we can expect both osmosis and diffusion happening in case of the peritoneal dialysis. Oops. Oh, yeah.
Peritoneal dialysis, both diffusion and osmosis, both are done.
Well, for in case of glucose, since it's a small size molecule, it can easily penetrate through the membrane of the peritoneal cavity that we use as the natural mass exchange unit. So this is just a simplification of osmosis. We can imagine a system where there's semi-permeable membrane that can, for instance, if we use as an example a filter from reverse osmosis unit, so it can be made in the same manner that it will allow the molecules of water pass through this membrane, but the solids will stay here. So this process will happen until the concentration of the solids become equal on both sides. But in case of peritoneal dialysis, since the glucose is a small-sized molecule, it will easily diffuse through the peritoneal cavity. That means that we will observe on the one side the osmosis that is created by the gradient, concentration gradient of that particular solute. And at the same time, we will observe the diffusion of glucose from the peritoneal solution to blood of the human patient. So it's more like a more complicated issue here, because we have to make sure that the concentration of osmotic agent is always high in peritoneal solution. Otherwise, when the concentration goes even, the lymphatic system will remove water back to human organism, which is quite dangerous situation in terms of peritoneal dialysis. Yeah, convection transport happens when some amount of the high-sized molecules will transport through the membrane with some volume of water. So it's a transport that can happen due to transmembrane pressure as a driving force of the conventional transport. So it's actually not a diffusion, but a transport of some solutes with some amount of water that goes through the semi-permeable membrane. Yeah, and that's just a small breakdown of hemodialysis. So if we talk about the hemodialysis system, it relies on diffusion and ultrafiltration that we create through the hydrostatic by means of increasing hydrostatic pressure of blood. And what we actually expect that the small solutes will easily penetrate the semi-permeable membrane of the hemodialysis fiber that goes in the mass exchange unit. So it will go from blood to fresh dialysate unit. And this process will happen until the concentration of the solute goes even. And at some points that can be expected, the convention transport, if we create a very high transmembrane pressure that allows the proteins to go to the ultrafiltrate with some amount of water that will filter out during the hemodialysis system. So the diffusion happens usually for small-sized molecules that are below the 1 kilodalton size, and for high molecule solutes, we can expect the conventional transport. Yeah, this is usually how the typical dialysis center looks. So there are a lot of hemodialysis apparatuses that are connected to water preparation systems. So the main issue that we will address on Lection 3 is the water consumption, because in order to perform an adequate hemodialysis procedure for a patient with chronic kidney failure, one have to take into consideration that we have to prepare a huge amount of dialysis solution, because if we use the restricted volume of dialysis solution, we can expect that at some point of the hemodialysis procedure, the concentration will go even, and we will not be able to remove the extra solutes from the human organism. So in order to increase the efficiency of the hemodialysis approach, we have to constantly remove the spent dialysis solution from mass exchange unit and pour the fresh solution from the system to continue the procedure. And in order to perform one procedure of hemodialysis for the patient who suffer from chronic kidney failure, we have to spend at very least 150 liters of dialysis solution. And it's just a part of the problem because we need to prepare a specific type water that will be acceptable for the preparation of the dialysis solution. That means that this water will not be contaminated by any microorganisms. There will be no mechanical particles in this water. There will be no significant ion concentration in the dialysis in the water that we use for the dialysis preparation. And basically, for one procedure, we will have to spend even more water to prepare this amount of dialysis solution that we can use for one patient for one procedure. And of course, these hemodialysis centers require a specific room where we can establish the filters to remove osmosis, where we should use the carbon filters and other types of filters that can prepare the water that will actually meet the requirements for procedure of hemodialysis, because even a small contamination of water can affect the quality of dialysis solution. In turns, it will create danger for patients if we use the contaminated dialysis solution. So just a small reference numbers. When I used to be a postgraduate student about 10 or 12 years ago, and when I was looking through the manuals of Fresenius, it's a main company that develops the apparatuses of hemodialysis and different equipment and spendable materials to perform the hemodialysis solution. They had a reference number that specific conductivity of water that should be used for preparation of dialysis should be less than 50 microsiemens per centimeter. Right now, if we look through the manuals and we look for the reference numbers for the water that should be used for preparation of the dialysis solution, this particular number is even lower. It's now about 1 to 3 microsiemens per centimeter. So basically, it's a distilled water, a technical distilled water. So there is a very strict demand for any hemodialysis system in case of what water should be used. And these restrictions are even more strict in case of microorganisms that can be presented in the tape water or anywhere else. That means that the usage of remove osmosis is like the main requirement to make sure that there will be no microorganisms presented in the water used for the dialysis solution. So basically, it's a method that requires a huge amount of water for only one patient, which makes this method quite expensive. And this system are usually stationary. Even if we talk about the home dialysis system, the patient will still require to perform this method at home, so he will not take it anywhere else. And if he performs that at home, he will require the specific water preparation unit to actually perform this hemodialysis without any risk of blood contamination. Yeah, that's just a small breakdown of typical hemodialysis apparatuses. Of course, different models of hemodialysis apparatuses varying from different brands and companies that create these apparatuses will vary, but usually they have the same requirements. Like in terms of dialyzer, if we return blood from the mass exchange unit back to patient, we need to make sure that there will be no bubble presented in this blood system. Otherwise, there will be a very dangerous condition for a human patient, for a patient, when this air bubble goes to the blood system, and it can result in the heart failure. That means that this particular system requires a blood detector, a bubble trap, and bubble detector. There should be a liquid level control and air trap, because usually it's a very simplified version where there is some level of water, and it has some empty space. So when the water with bubble comes in, the liquid goes under the gravity down during the bubble trap, while the gas goes away from the bubble trap. So in order for operation of that air control, we need to maintain the same level of water in the bubble trap. So at the same time, there should be the detectors of blood presence in a dialysis solution, because we need to make sure that the membrane of the mass exchange unit is not permeable, not just for proteins, but for blood cells as well. There can be a condition when there is some poorly manufactured mass exchange unit, or at some point of the hemodialysis, we exceeded the transmembrane pressure that led to the malfunction of membrane. That means that the blood will go from the perfusion part of the dialysis to the dialysis itself. That means that patient will start losing blood in that case. And in case of the when we talk about the dialysis circulation, at the end of the dialyzer unit, we need as a requirement a detector of blood cells in the dialysis. So we will make sure that we will not remove the blood itself from human patient. So yeah, basically those apparatuses require also the sensors of the dialysis pH, the conductivity of the dialysis, the different monitors that control the temperature of the dialysis, which is very essential, because when we contact with human blood, we need to make sure that we will not overheat it or cool it down. So we need to make sure that different parameters of the dialysis solution will meet some criteria to make sure that this particular process is safe for a human organism. Speaking of peritoneal dialysis, as we mentioned before, in order to perform oh, sorry, there is some Russian letters here. So in order to, yeah.
In this slide.
Yeah.
Sir, for bubble trap, you have draw a arrow to like this venous pressure monitoring system. What is the relation between this?
Yeah, there should be at least some detector that can detect the bubble system in case of our bubble trap did not work properly. Because if the bubble system does not provide a removal of the bubbles from the solution, there is a danger that these bubbles go back to the human blood system, and that will create a very dangerous condition. And this sensor should have a feedback loop with hemodialysis system. So there is automatic shutdown in case if there is some malfunction with any part of the dialysis system in this regard.
Is there any microbubble that can be trapped from the bowel? Is there any possible any microbubble that cannot tap out from this trap system?
Well, there can be some size of the bubbles that are not detectable, so they are so small that there is no way to detect them, and there is no way to remove them from the bubble trap. But usually, in general, we have to manufacture a system that will prevent the continuous flow of bubbles of any size, to make sure that we will not harm the patient. Well, they can recirculate back into the human organism, and they can end up in the human heart that can lead to the fibrillation of human heart, as far as I know, which can lead to the stop of the human heart. And they can accumulate in different body parts during the circulation. So we need to make sure that they will not accumulate anywhere in human blood, because it's a dangerous condition, first and foremost for heart, if I recall correctly. Yeah, in terms of peritoneal dialysis, as we mentioned before, we need to create a specific ultrafiltration flow that we control by means of introducing the osmotic agent that creates the gradient of osmotic pressure. So this is basically a typical composition of many types of the peritoneal solution. Here you can see the example for Fresenius. So we need to make sure that the concentrations of these ions are more or less the same as the concentrations of those ions in human blood, with the only exception that sodium is usually a little bit lower in comparison with sodium level in human organism, to make sure that we will remove some extra sodium from human blood, because in case of kidney failure, when people consume food, they will acquire additional sodium, and we need to remove it through the renal replacement therapy. And of course, one of the main components of this dialysis solution is the osmotic agent. Usually it's glucose. Here's the small breakdown of the 3-pore module that describes the transport in the peritoneal dialysis. So basically, we can consider the semipermeable membrane as a heteroporous membrane that consists of very small transcellular pores that actually provide only the transport of water molecules. There are some small size pores that provide the diffusion of small solutes, and there are large pores that provide the conventional transport of macromolecules and the diffusive transport of any small solutes through these pores. That's basically the breakdown in order if there is a necessity to consider the removal strategies for many solutes of different size. This is the ratio of metabolite concentration in peritoneal dialysis solution and plasma in case of the peritoneal dialysis. So we can expect that urea will diffuse through the membrane pretty much easily. It's a very small molecule, and if we actually write down the molecular mass of urea, is glucose, and that's urea, it will be about 60 gram per mole. And for creatinine, it will be 113 gram per mole. So we can expect that creatinine as a bigger molecule will filter a little bit worse than urea. And if we talk about the middle-sized molecules, since during base size, the diffusion of these molecules will become even slower. So in the case of the dwell time, even if we actually wait for a very long time, we will remove only about 60% of B12 marker from the during the peritoneal dialysis. This is basically a relationship. Yeah, just a small notion. That's a relationship of the concentration of the solute in dialysis solution and plasma. So it means that the diffusion process for huge molecules will be twice as slower in comparison for small sized molecules. So we can expect that during the dwell time we will achieve the even concentration for urea, and we will not be able to achieve the same ratio for bigger sized molecules. Speaking of ultrafiltration, as I mentioned before, we should consider the alternatives for the osmotic agents, because there should be noted that in terms of chronic kidney failure, many patients with chronic kidney failure actually develop diabetes as well. And if we use the glucose as the main osmotic agent for ultrafiltration, that means that we need to control the glucose blood level, and if we do not want to harm a patient with the diabetes. So different alternatives should be taken into consideration. One of them is ecodextrin. Amino acids can be potentially used for that purpose. But this particular graph actually provides the idea of how exactly the concentration of specific metabolite and how the size of the molecule affects the ultrafiltration rate. So for the glucose, we can expect, if considering it's a small sized molecule, that the ultrafiltration flow will become reverse in the matter of few hours. And if we continue the ultrafiltration flow, we will expect that the ultrafiltration volume in the peritoneal cavity will start drastically decrease due to the presence of lymphatic flow. So in order to make this process more continuous, we can use the bigger molecules, but the problem with bigger molecules that they create a lower osmotic pressure. So if we actually consider the molecular mass and consider the concentration of these molecules in the solution, they will not create this drastic difference of osmotic pressure as the small size molecules. So on the one hand, icodextrin is a preferable osmotic pressure agent because it provides a very continuous ultrafiltration flow. On the other hand, this ultrafiltration flow is quite low in comparison with the osmotic pressures, osmotic agents like glucose. That's just a small table that provides the information about different types of peritoneal solution. So there you can see the osmotic agent, the pH of the solution, and different compositions of the ions and other substrates that are dissolved in these solutions. In order to perform adequately the peritoneal solution, a doctor actually requires to perform the peritoneal equilibrium test. It's basically a test that provides the doctor a better outlook about the diffusion capabilities of peritoneal membrane in order how fast some specific markers will diffuse through the peritoneal membrane, including the osmotic agent glucose, and how fast we can remove sodium. And at the same time, a doctor will have a better outlook of how the ultrafiltration works for different patients. So basically, you have a small breakdown with high permeability membranes. And if we look at the DP, what it actually means is the relation of the, okay, let me erase this. So GP means the concentration of the solute in peritoneal dialysis, and P is concentration in plasma. So what it means is how fast the concentrations of these particular substrates become equal at some amount of time, and whether they become equal, it allows to roughly estimate the permeability of the membrane for the specific substrates such as urea, creatinine, sodium, and glucose. And it allows to estimate the amount of dwell time that should be used for specific patients with specific membranes, because unlike in hemodialysis, where we can manufacture a standard membrane for a dialyzer system, all people are unique and they have unique transport properties for any specific patient. So in order to make this process effective, we need to estimate the membrane capabilities before a doctor will perform the procedure of peritoneal dialysis. Those are different modalities of peritoneal dialysis. Usually people use the continuous ambulatory peritoneal dialysis, where patient changes the peritoneal solution at least 4 to 6 times a day. There are some modalities for automatic peritoneal dialysis, when we have a cycler, a system that will automatically renew the solution inside of peritoneal cavity. And they could be a day dry modality, some modality with day dwell, etc., and so on. It depends on the conditions and residual kidney properties that the specific patient will have. Yeah, we already addressed this particular image. So we consider the organ transplantation a golden standard of renal replacement therapy, but due to a shortage of organ transplants, we have to rely on dialysis as the main mean to help patients with human with chronic kidney failure. And this is basically the distribution between hospital-based hemodialysis and peritoneal dialysis and home-based dialysis. Right now, there is a trend, like one of the most prominent trends in renal replacement therapy development is an attempt to create the conditions where patients will be able to perform this dialysis at home. So it basically will increase the comfort and the ability for a patient to perform this procedure daily. Because from the first lecture, we actually mentioned that the human kidney on itself can filter blood continuously without any stop or any rest. And it does not matter if we sleep, if we active, etc. So kidney constantly works, kidney constantly filters blood. The problem with the renal replacement therapy is we cannot achieve the continuous blood filtration. So one of the prominent trends is to create a home dialysis system that will allow a patient to perform the dialysis process on a daily basis. In comparison, for instance, when people have to go to the dialysis system 3 or 4 times a week, and it's still not a continuous procedure. So, in order to increase the quality of renal replacement therapy, one of the trends is an attempt to uh, turn the renal replacement therapy a home-based procedure that will increase basically the quality due to ability of the patient to perform it daily. Yeah, that's basically the.
So in our country, the peritoneal dialysis is not so popular. Hemodialysis is mostly used. Peritoneal dialysis has not. But in Russia, what is the situation?
Well,
Peritoneal or
yeah, I think it's the common issue, like the peritoneal dialysis is not very popular in Russia either. We have these centers that actually perform peritoneal dialysis, but about 80% of patients, they still require hemodialysis. And I think the problem is that not every patient has the appropriate membrane for good quality peritoneal dialysis. Peritonitis is another issue of the peritoneal dialysis. There is a chance that due to very frequent exchange of peritoneal dialysis, we will contaminate the peritoneal cavity, which will lead to inflammation of the peritoneal cavity, and it returns. The patient will not be able to perform this procedure anymore. He will still require hemodialysis. And yeah, the main complication is how to make this procedure completely safe for a for a patient. I'm sorry, for human is excessive word here. For a patient, of course. Yeah,
and more awareness is required.
yeah,
Awareness of the how to operate.
yeah. How to operate in case of automatic peritoneal dialysis. Yeah, we need to make sure that all circuits of this peritoneal dialysis system are sterile. They have no connection with outer medium, so there is no way to contaminate any pumps or tubules inside of that system. So the contamination issue is a very huge problem in terms of peritoneal dialysis.
Any questions? Yes. This, in this lecture too, I think we have finished. W, if you want to know anything or you can do so. There is no question. I think then we can. I think the end of the first morning session is over.
Yeah.
I think.
Yeah, thank you for your attention.
So the morning session is over with
Yeah.
the 2 lectures, and now there is a lunch. Okay, and again we'll come back. I think at 3 o'clock. 3 to 4 is the first session. I think everybody have received the schedule. Every day there is a 3 actually lectures. Okay, 2 in the morning and 1 in the afternoon. Okay. So please take your lunch. There is a time, sufficient time, and please come back 15 minutes earlier and take your seat, because we have to start in time because there is a YouTube link already been shared to the history, and we cannot deviate the time from what we have already fixed it. Okay, so there is some kind of guidelines of the care is there. It's not like just I can start at any time. So we have to maintain the timing. So please come back at least 8 to